Hi, I'm Dr. V. I'm an interventional pain physician at Bloor Pain Specialists. Today, I will be addressing some common questions about epidural steroid injections.
What are the risks associated with epidural steroid injections?
Epidural steroid injections are amazingly safe. Statistically, there's about a 1 in 800,000 risk of anything scary. We're talking about paralysis, nerve damage, that sort of stuff. That's the most aggressive estimate, which is safer than walking on a city street or driving a car. On the other end of the spectrum, the more conservative estimates put epidural steroid injections at 1 in 2.3 million for a rate of injury. And these are done so often that those numbers are real. They're reliable. Over 20 million times annually in North America. Less scary, but more common complications are relating to the needle. So for example, you might expect a pinch. Small, fine, but we consider that a complication. It's a discomfort to our patients. So we use freezing. We like people. So we're going to freeze the skin, we're going to freeze the soft tissue. We'll be kind. You might expect a bruise. Again, small, but potentially there. Now, patients on blood thinners should not be getting epidural steroid injections until their cardiologist or family doctor or whoever's managing their blood thinners tells them that they can be off of their blood thinners for the appropriate amount of time so they don't develop a big or dangerous bruise inside. There are complications with infection, or at least the potential thereof, every time there's a hole in the skin, whether it's a scratch at home or our pets scraping our skin or a needle going in or surgery in the hospital. When we're talking about these needles, they are very small. It's a tiny pin. We use a surgical disinfectant that cleans the skin, disinfects everything, kills all bacteria, and that stays on the skin to keep people safe. That leaves people at a rate of infection that is very low. Statistically, about 1 in 10,000 or less. 1 in 10,000 equates to 1 in 28 years if the procedure is done absolutely every day, which obviously it would never be done as such. Some people will have an allergic reaction to one of the components in the procedure. Sometimes it's the disinfectant itself. Sometimes it's the dye in the disinfectant. Sometimes different brands have different colors, pink, orange, brown, and those are dyed that way so that the skin, we can see which areas are clean and which aren't. That's very important to protect our patients. But in some cases, those dyes will be irritating to the skin, cause itchiness, cause hives, and that sort of skin type reaction. Internally, we use a X-ray dye. X-ray dye, or contrast, differs between contrast for MRIs and contrast for X-rays. This contrast is a contrast that we use for with low likelihood of reaction, but it's always possible. And that sort of reaction can manifest in different ways. If it does become a reaction, we have the medications to treat these reactions on site.
I've heard cortisone is bad for you. Is that true?
Excellent question, and a really common one. Cortisone in itself actually hasn't been injected into anyone in North America in about 30 years. We just keep saying cortisone because everybody understands what cortisone means. Cortisone is a small molecule though. It can fit into capillaries and wash throughout our body very easily. If you inject into a knee, it'll end up in your ear, your foot, your eye on the other side. And that's why it's not useful as an injection. When we inject medications in that same class as cortisone, corticosteroids, well, we inject large molecule cousins, powder-based cousins that cannot fit into capillaries. They simply can't go away. They can't wash to another part of the body. And so they stay where we put them. And so that means the effect is local and the side effects are local. Now, cortisone does have side effects. That's absolutely true. And it's one of the big reasons why everyone has concerns about cortisone. It can change your metabolism. Blood sugars vary. It can change where fatty tissue is deposited. It can change our shape with that. It can cause water retention. People can gain weight. Diabetes can be affected. Kidney function can be affected. All kinds of organ systems can be affected with a molecule that spreads throughout the whole body. And that's why we use variants that don't spread at all. or at least very rarely so. Cortisone also has a very important effect on bone density. And that is true of the old cortisone that isn't used anymore and the cousins of cortisone that are used today. There was a great paper, a randomized controlled trial out of the Journal of the American Medical Association, published on knee injections with triamcinolone versus saline. Triamcinolone is a very common injectable version of cortisone with large molecules. It is often used for shoulders and hand arthritis and knees and hips. But this trial showed that over the course of 2 years being injected every 3 months, there was more decay in the cartilage, the soft tissue, the connective tissue in the knee with the triamcinolone, the cortisone group, than there was in the saline group. And both groups had good blinding, meaning that patients didn't know what they were getting and physicians didn't know what they were giving. They were given blind syringes covered so they didn't know what was inside, so that there was no bias. You couldn't alert somebody to say, aha, you're in this group, you're in that group, so their behavior changes. It was very well controlled, so that the only real variable that was detectable was the difference of cortisone versus saline.
How long does an epidural steroid injection last?
So steroids as a class will typically last 6 to 10 weeks, but that's not really the answer that people want. People want to know, how long will I feel better? Well, we've got to think about that as a different question. The length of the steroid injection, the pharmaceutical curve, well, that's like asking, how big is my fire extinguisher tank when you want to put out a fire? If you've got a fire in the corner of the room, well, as long as you put out the fire with your tank, the fire's gone. It doesn't matter if you had a little tank, a medium tank, or a giant tank. You don't really care how big is my tank as long as it gets rid of the fire. Ultimately, the goal is to feel better, to have the fire gone. Now, if the fire's gone, you put out the fire in the corner of your room, how long does that last? Forever. Unless there's a reason to bring back the fire. So if it worked perfectly and got rid of all the fire, epidural steroid injections can last for many years. But it is important to recognize that the fire, the injury, the swelling, the inflammation, the disc bulge that's pinching the nerve in the first place happened for a reason. There was some movement, some weakness, some injury in that part of that person's body, and they're probably going to be somewhat prone to it. So it's important to do all the rehabilitative exercises, to do the yoga, the Pilates, the strengthening, the core work, to make sure you stay safe and prevent that nerve from getting inflamed again, that disc from herniating again.
How often can epidural steroid injections be repeated?
The government of Ontario recommends that the most frequent injection of epidural steroids would be every 3 months. That is the most frequent. In some very rare cases, it is indicated to do it more often, but 3 months reflects that pharmaceutical curve of the steroid medication lasting about 10 weeks. Now, in the majority of cases, this lasts much longer in terms of the patient benefit. Patients feel better for longer even though the pharmacy's gone. And so they don't need these procedures done every 3 months. In most cases, they only need them once or twice a year, if that.
Is there a maximum number of times ESI can be repeated?
This is an excellent question and an evolving one. We continually look at the data, reassess and reassess in medicine. The information now tells us that by injecting epidural steroids, there are some long-term implications. For one, there are implications on the fatty tissue in the epidural space. It can grow. And if it grows, by changing local metabolism, having the same injection in the same area for the same disc and the same nerve, again and again every 6, 9 months, 12 months, over the course of a decade. Somebody might have a better quality of life. They might walk more, they might do more, they might be able to work more, they might enjoy their life more. But locally in that tissue, the metabolism changes. And a fatty deposit within the epidural space can grow. This is not visible through the skin. It's deep. It's actually within the spinal column, but it can occupy space that can make the nerves a little uncomfortable. And that can change the scenario of how somebody is treated in the long term. Another common consideration is the bone density changes that come with corticosteroids. Bones can weaken with the injection of cortisone or any cousin of cortisone. And we measure bone density with a measure of a 10-year risk of fracture. So if somebody has less than 10% risk of fracture over the next 10 years, they're thought to have normal bone density, to be low risk of having bone density complications. So if somebody is relatively young, they're athletic, they're strong, they have good nutrition, their fracture risk might be as low as 1%. And corticosteroids will increase the risk of fracture by an average of 21% over a 10-year span. That doesn't mean it goes from 1 to 22. It goes from 1 to 1.21%, which is a very small change. But it's an important one if somebody's starting off at 20% risk, 30% risk, 40% risk, if they've already had 2 fractures, 3 fractures, 4 fractures. Those are the patients that we really have to be worried about, thinking about what are the long-term implications, how many should this patient have, what are their risk downstream? Because they may be significant, and those complications may be a massive detriment to their life despite the relatively short-term or medium-term benefits of the epidural steroid injections.
Can epidural steroid injections be done if I've already had spine surgery?
So ESIs can be performed with the guidance of X-ray, but it is important to note the technique changes. When spine surgery is done, something has been changed. Surgery changes anatomy. Surgeons cut tissue. Tissue heals, tissue scars. So some of the classic techniques have to be modified for patients who have had surgery. In most cases, ESIs are still possible. They can be done with the guidance of our mobile X-ray machines as they look through people at different angles. In some cases, though, there are complications of surgery, or the patient has not healed well, or their bone has grown dramatically, occupying too much space, and there just isn't an entry angle to get into the epidural space without being too invasive. Unfortunately, in those cases, an epidural steroid injection may not be possible. If you have any general questions you'd like us to discuss, please leave a comment below. If you'd like to discuss anything specific about your care, please contact our clinic. Don't forget to like and subscribe. Thank you for watching this video.